Hello everybody. Today we are going to discuss about intracranial hypertension. Intracranial hypertension is the common clinical problem in the intensive care unit, which requires the immediate and urgent treatment. Intracranial hypertension is the result of either primary central nervous system lesion or complication of coexisting systemic disease. It is caused by a variety of conditions divided into five main categories based on their pathological mechanism. Any condition affecting CN is defined as acute brain injury, and it has a two component. That is primary brain injury that cannot be reversed and secondary brain injury. Secondary brain injury is defined as any physiological event that can occur within minutes, hours, or days after initial injury and leads to further damage of nervous tissue. It can be detected through the clinical examination and intracranial pressure monitoring, as it is mostly due to increased ICP and confirmed by imaging testing. Now, causes of intracranial hypertension. So, first mechanism is venous obstruction. The etiology is sinus venous and jugular vein thrombosis. Then increased brain volume. Etiology is brain tumor, abscess, empyema, intracerebral hemorrhage. Then because of increased blood volume, which occur because of hypercapnia, anoxia, severe anemia, hyperperfusion syndrome, AV malformation, and AV fistula. Then because of mass effect, which occurs because of subdural hematoma, epidural hematoma, empyema, and tension pneumocephalus. And then cerebral edema, which occurs because of cytotoxic edema, which happens because of ischemic stroke, anoxic encephalopathy, fulminant hepatic failure, vasogenic edema, which occurs due to hypertensive encephalopathy, brain tumor, abscess, encephalitis. Then ependymal, which occurs because of subarachnoid hemorrhage, meningitis, idiopathic intracranial hypertension, and osmotic. It occurs because of hyponatremia, decay, osmotherapy, rebound effect. Now, causes of secondary brain injury is intracranial. Intracranial is because of intracranial hematoma, cerebral edema, intracranial hypertension, CNS infection, and seizure. Extracranial is because of hypotension, hypoxia, hypercapnia, electrolyte disorder, hypoglycemia, hyperthermia, coagulopathy, and infection. So this is the pictorial representation which representing primary and secondary brain injury. So primary brain injury, which leads to the structural and functional changes, it results into ischemia as well as cerebral edema, which leads to the intracranial pressure. Intracranial pressure leads to the secondary brain injury. So symptoms and signs. Symptoms and signs are headache, nausea, vomiting, diplopia, decreased level of consciousness, papilledema, pupillary dilatation, downward deviation of the eyes, Cushing triad, which is characterized by severe hypertension, bradycardia, irregular respiration. Headache is often described as exacerbated by coughing, sneezing, recurrency on exertion, and in the morning. Nausea, vomiting will be projectile, not relieved by medication. Diplopia will occur because of sixth nerve palsy. Decreased level of consciousness will occur because of drowsiness to coma. Then papilledema is a reliable sign which may develop after several days of increased ICP. Pupillary dilatation is result of third cranial nerve palsy. Downward deviation of the eyes due to dysfunction of upward center in the dorsal midbrain. Then these are the types of herniation. So first one is uncal herniation. It is the inferior displacement of the medial temporal lobe past free edges of the tentorium cerebellum. It causes the ipsilateral ocular nerve palsy. PCA infarction. Then central transtemporal herniation is the progressive downward displacement of diencephalon and brainstem, results into the coma, diabetes insipidus. Then subphallacean herniation causes the compression of cingulate gyrus under falx cerebri. It results into ACA infarction and contralateral leg weakness. Then transcalvarial herniation, when brain displaces outside the cranial cavity via cranial defect. Then ascending transtentorial herniation, There is a upward displacement of cerebellum through tentorial phenomenon causes the compression of the midbrain, result in coma, absence or asymmetric oculocephalic reflex, and a decerebrate posture. Then tonsillar herniation, which is a downward displacement of cerebellar tonsil through foramen magnum. Results into the cardiorespiratory dysfunction and arrest. Then ICP monitoring. In clinical practice, invasive and non-invasive methods of ICP monitoring are used aiming to determine the optimum cerebral perfusion pressure. Invasive ICP monitoring. Intracranial hypertension is associated with poor outcome and particularly with increased mortality. So it seems reasonable to measure ICP. Indeed, in randomized trial involving patient with severe traumatic brain injury, ICP-guided therapy was not shown to be superior to care based on imaging and clinical examination. Recent studies have also yielded conflicting results. Invasive ICP measurement is performed by specific catheter inserted into intraventricular, intraparenchymal, epidural, subdural, and subarachnoid space. Ideal ICP monitoring device should be reliable, accurate, cost effective, and be associated with minimal morbidity. Today, intraventricular catheter remains the most reliable method for ICP monitoring as it measures the global ICP provided that no obstruction to the CSF flow occurs. So main features of ICP monitoring catheter is discussed below. So intraventricular catheters are more accurate. It represents global ICP, lower cost, can be recalibrated in situ, can drain CSF as ICP lowering therapy, higher risk of infection, difficult to place in the brain with severe edema. Then intraparenchymal catheter is fairly accurate, may not represent global ICP. It has higher cost, inability to recalibrate, inability to drain CSF. There is lower risk of infection and easier to place. Recently, the intraparenchymal catheter used for ICP monitoring have integrated a CSF drainage catheter and catheters that detect parameters such as brain tissue O2 partial pressure and cerebral blood flow. Epidural, subdural, subarachnoid catheter are less accurate and therefore rarely used. Now about non-invasive ICP monitoring. No methods of non-invasive ICP monitoring can replace invasive monitoring, but may be useful either as a complete complementary tool or in deciding whether to initiate invasive monitoring. Then the methods are brain CT, computed tomography. CT evaluate rapidly the presence of specific finding that enhance the diagnosis of intracranial hypertension. These include mass effect, midline shift, cerebral edema, hydrocephalus, compression of basal cistern, and changes in the gray-white matter differentiation. Then brain magnetic resonance imaging. MRI shows more detailed soft tissue cerebral parenchymal lesion, which may not have been detected on CT. Diffuse axonal injury. However, prolonged screening time and stay of the patient in supine position may aggravate ICP, make its use limited to the patient with suspected intracranial hypertension. Then transcranial Doppler ultrasonography. Transcranial Doppler ultrasonography is useful bedside non-invasive technique for detecting inadequate cerebral blood flow and assessing cerebral autoregulation. It may indicate the need for invasive brain monitoring and direct treatment in multifactorial multimodal neuromonitoring approach. TCD detects blood flow velocity through major intracranial vessel, most commonly middle cerebral artery. In cases of elevated ICP, the external pressure in the cerebral vessel increases, which is reflected by changes in the flow velocity. Detection of reduced flow velocity indicates impediment to cerebral blood flow and indirectly increased ICP. Besides the mean flow velocity, pulsatility index and slope of the transcranial Doppler waveform have been correlated with the ICP. It has been found that pulsatility index changes in the middle cerebral artery are associated with changes in the ICP when later is between 5 to 40 mmHg. However, the accuracy of technique depends on the experience of the operator, and in addition, 10 to 15% patients do not have adequate bone wind. Optic nerve sheath diameter. The space between optic nerve and the sheath is filled with the CSF. Therefore, its pressure equals the ICP. Thus, optic nerve sheath diameter measures using transocular ultrasound is increased in the patient with intracranial hemorrhage. Some studies have shown that optic nerve sheath diameter of more than 5 mm corresponds to the ICP of more than 20 mm. This association may be affected by the conditions such as tumor, inflammation, Graves' disease, sarcoidosis, which may alter the optic nerve sheath diameter. The optic nerve sheath measurement technique is cheap, efficient, non-time consuming, but operator dependent. Now, tympanic membrane displacement. Because of the CSF and perilymph communication through cochlear aqueduct, an increase in ICP is indirectly transmitted to footplate of the stapes, displacing tympanic membrane from its initial position. Inward displacement indicates the high and the outward normal or the low ICP. However, this technique lacks the accuracy and is unreliable method of quantitative assessment of ICP in the clinical practice. Now, this is the summary of the non-invasive ICP monitoring. First is brain CT, which is fastest and the cost-effective method. Then brain MRI is more accurate assessment of soft tissue and cerebral substance lesion. Transcranial Doppler ultrasonography, patient bedside, high operator dependent. Optic nerve sheath diameter is the cheap, efficient, not time consuming. Tympanic membrane displacement is inaccurate and unreliable. Now, additional tools are brain tissue O2 partial pressure. Measurement of the brain tissue O2 partial pressure by inserting microcatheter in the white matter allows to unmask, reduce perfusion and insufficient O2 supply and also unmask underlying hyperemia. However, the measurement is regional as only approximately 15 mm of tissue around the tip is sampled. Current multimodal consistence consider PbO2 of less than 20 mmHg as threshold to consider intervention. Studies have shown that low PbO2 can be observed in combination with either high or low ICP, which enhances the value of brain oxygen monitoring. Thus, multimodal consequences suggest that its use to assess titration of medical and surgical therapy, to guide ICP and CCP therapy, identifying refractory intracranial hypertension and treatment threshold, and help manage delayed cerebral ischemia and select patients for second tier therapy. Initially, tendency to better outcome with combined PbO2 and ICP CCP therapy compared with ICP upon CCP therapy alone has not shown in severe TBI. Now, jugular venous oxygen saturation. Measurement of jugular venous oxygen saturation by a catheter placed in jugular bulb would be used to estimate the balance between cerebral oxygen delivery and demand. Then so jugular venous oxygen saturation differentiates insufficient oxygen supply due to impaired cerebral perfusion, that is less than 50%, from reduced cerebral oxygen consumption encountered during hyperemia. Increased ICP is associated with reduced jugular venous oxygen saturation. It could be part of multimodal modality or be used in conjugation with ICP monitoring, but it is more difficult to use and less reliable than PbO2 monitoring. Due to the inherent shortcoming of the method, it can only be provide information about global metabolism and its use has been limited. Now, cerebral microdialysis. Cerebral microdialysis allows for semi-continuous measurement at bedside of numerous parameters, including glucose, glutamate, lactate, pyruvate, and glycerol concentration. Metabolic changes of this parameter may occur before the usual cerebral physiologic and pathophysiologic changes, namely when ICP is not. These changes may precede the clinical features of delayed cerebral ischemia and intracranial hypertension, allowing early therapeutic adjustment. In addition, derangement in the cerebral metabolism detected by microdialysis can reveal the extent of deleterious effect of intracranial hypertension on the brain. However, microdialysis cannot be widely implemented yet due to its time consuming maintenance and additional cost. Now, near infrared spectroscopy. Near infrared spectroscopy is the non invasive tool that measures the cerebral oxygenation by detecting oxygenated to deoxygenated hemoglobin concentration. However, its use is limited in clinical practice since to date there are no studies to establish absolute threshold for cerebral hypoxia and conditions such as scalp swelling and epidural or subdural hematoma lead to unreliable measure. Now, continuous EEG. The use of continuous EEG is indicated in detection of convulsive and non-convulsive seizure and prognosis of coma. Moreover, the continuous EEG can be used in the case of increased ICP as it is affected by changes in the cerebral metabolism. EEG pattern associated with elevated ICP include focal slowing of underlying rhythm, global EEG suppression progressing to burst suppression or flat EEG. At the same time, continuous EEG is remarkably sensitive too for detection of cerebral ischemia since it can reveal changes in neuronal function before structural damage. This is due to its high sensitivity to detect changes in the cerebral blood. Finally, continuous EEG can help predict outcome and titrate treatment such as barbiturate. Now about management of intracranial hypertension. Progress in monitoring and understanding the pathophysiological mechanism of intracranial hypertension allows implementation of targeted intervention in order to improve the outcome of this patient. In ICU, all efforts should focus on preventing secondary brain injury, although management of primary cause of intracranial hypertension is the basic initial approach. Prevention, detection, and treatment of secondary brain injury are priorities of paramount importance for clinical outcome of the patient. Several molecular and cellular pathways are activated in secondary brain injury. Third, changes in the ionic permeability, release of excitatory neurotransmitter, increased free radical accumulation, causes mitochondrial dysfunction, which further triggers energy defect and process of necrosis and apoptosis. These molecular and cellular changes could lead to development of cytotoxic and vasogenic brain edema, disturb autoregulation, resulting in increase in volume of intracranial component due to vasodilation and water accumulation or both. Secondary brain injury is predictable and treatable and may be the result of extracranial or intracranial factors. Indeed, hypoxia or arterial hypotension triggers the SIRS response, which may further aggravate development of secondary damage. Trauma affects the blood-brain barrier directly with increased permeability, favoring vasogenic edema formation and activation of pro-inflammatory state. Seizure may aggravate the imbalance between energy expenditure and supply. The control of all these variables has been shown to improve both neurological and functional outcome of the patient. Pathophysiologically, the management of raised ICP focuses on four main axes. That is control and manipulation of vasoreactivity, cerebral blood flow metabolism coupling, managing the blood-brain osmotic gradient, reducing the metabolic rate of oxygen consumption of cerebral tissue, physical and surgical modalities which affect intracranial compliance. According to the last guidelines for TBI, the primary goal of intracranial hypertension treatment is to maintain intracranial pressure below 22 mmHg, cerebral perfusion pressure above 60 mmHg. Achieving these goals could be life-saving for brain viability. The therapeutic measures for intracranial hypertension are distinguished in general prophylactic measure and those applied in acute phase in order to urgently reduce ICP and optimize CPP. All these interventions should be applied with the staircase approach.
That is, first one is the main aim should be CPP should be more than 60 to 70 mmHg. ICP should be less than 22 mmHg. So first step is the general prophylactic measure. Then second is resection of mass lesion, CSF drainage, hyperosmolar therapy, hyperventilation, therapeutic hypothermia, barbiturates, and decompressive cranial. So, general prophylactic measures are intubation mechanical ventilation, BP CPP optimization, body positioning, temperature control, prophylactic hypothermia, glycemic control, seizure prophylaxis. An acute intervention is hyperventilation, hyperosmolar therapy, sedation, analgesia, barbiturates, therapeutic hypothermia, corticosteroid, resection of mass lesion, decompressive craniotomy, CSF lesion, and progestin. So we'll see one by one. Intubation mechanical ventilation. Early and rapid intubation and mechanical ventilation should be applied in comatose patient. This will help in controlling factor that may aggravate ICP, such as seizure and agitation. So during intubation, adequate depth of sedation and elimination of reflexes such as cough and vomiting should be achieved. Mechanical ventilation should aim at avoiding hypoxemia, hypercarbia, and hypocapnia. Hypoxemia and hypercapnia should be avoided because of linear increase in cerebral blood flow and hence ICP. Conversely, hypocapnia lead to increased risk of ischemia by including cerebral vasoconstriction and reducing CBF. Consequently, PCO2 should be maintained at values below between 35 to 40 mmHg. The use of PEEP during mechanical ventilation in patient with acute brain injury has a risk of ICP elevation and CCP reduction due to increased intrathoracic pressure and decreased cerebral venous drainage from superior vena cava. However, in clinical trial, this effect occur only when applying PEEP more than 15 mmHg in hypovolemic patient. So, Carey Cato et al. Concluded that the level of applied PEEP had no effect on intracranial system in patients with low respiratory system complaints. Also, there are data claiming that effect of PEEP on ICP depends on whether it causes alveolar hyperventilation or recruitment. Uh, in um, in particular, if PEEP does not achieve effective alveolar recruitment that causes hyperventilation, it results in increase in ICP due to impediment of cerebral venous return. So, blood pressure and CPP optimization. During blood pressure monitoring, hypotension should be avoided because it is an independent risk factor for poor outcome in patients with acute brain injury. The consensus of low BP are determined by state of cerebral autoregulation. In patients with intact autoregulation, hypotension triggers reflex cerebral vasodilation and increased cerebral blood volume. In contrast, in patients with impaired autoregulation, hypotension leads to cerebral ischemia due to CPP reduction. Nearly all patients with severe TBI exhibit hypotension even in the absence of hemorrhage. This is regarded as a result of both administration of sedation, analgesia, and severe SIRS. SIRS is induced by trauma and increased endothelial permeability, favoring volume shift and volume loss into third space. This hypovolemia may lead to inadequate CPP and subsequent ICP increase. According to the large retrospective study of 15,000 patients with isolated moderate to severe TBI, patient with systolic blood pressure of less than 110 mmHg should be considered hypotensive. According to Brain Trauma Foundation guideline, SPP more than 100 mg should be maintained for a patient of age 50 to 69-year-old, more than 110 for age between 15 to 49 and 70-year-old to decrease the mortality and improve outcome. Strict monitoring of the fluid balance is necessary in order to prevent hypovolemia hypotension.
Isotonic fluid should be used, and hypotonic fluid such as 5% dextrose and 0.45% saline should be strictly avoided. Systemic hypoosmolality should be aggressively reversed. Regarding the type of the fluid, that is crystalloid versus colloid, optimal choice will remain controversial. However, the SAFE study involving 460 patients with TBI compared fluid resuscitation with albumin or saline concluded that former, that is albumin, may be harmful and should be avoided as it was associated with high mortality rate. If MAP is more than 110 and ICP more than 20, systemic blood pressure should be carefully lowered in order not to decrease CPP significantly. Therefore, it is suggested to use short-acting titrable agents such as labetalol and nicardine. Guideline for ICH recommended the use of antihypertensive drug if SBP is more than 150 mmHg, as it has been associated with improvement in functional outcome, namely significant better functional recovery based on modified Ranskin scale, better physical and mental health related quality of life based on EQ5D scale. The optimal value target for CPP is matter of debate. The minimum CPP value required to prevent cerebral ischemia is generally acceptable at 50 to 60 mmHg. However, two distinct approaches have been developed with the differing views on whether CPP should be maintained at higher or lower level. The Rosner concept advocates an increased MAP aiming at high CPP value in order to maintain adequate cerebral blood flow. In contrast, the Lund concept advocates reducing intravascular resistance and hydrostatic pressure, reducing cerebral blood volume, thereby increasing cerebral blood flow and making lower CPP acceptable. According to the latest guideline, the recommended target CPP value is between 60 to 70 mmHg, as it has been associated with improved survival and favorable outcome. However, whether 60 to 70 mmHg is the minimum optimal CPP threshold is unclear and may depend upon the patient's autoregulatory status. At some time, aggressive effort to maintain CPP of more than 70 mmHg with fluid and vasopressor should be avoided because of risk of ARD. However, excessive elevation of CPP favors edema formation by increasing capillary hydrostatic pressure across blood-brain barrier. Therefore, it is worth noting that optimal CPP depends on peculiarities of each patient and should be individualized based on multimodal management. Advanced monitoring technique such as PbO2 and SjVO2 measurement, EEG and microdialysis may eventually allow clinicians to optimize CPP based on specific physiological circumstances in particular patient at any given point in time. About body positioning, the head of the bed should be elevated to 30-degree and patient's head face midline so that internal jugular vein is not compressed and cerebral venous drainage is facilitated. Head elevation may reduce ICP without adversely affecting either CPF and the CPP. However, head elevation in the excess of 45 degree should generally be avoided because paradoxical increase in ICP may occur in response to excessive CPP reduction. Important maneuver that protect against ICP increases include reducing excessive flexion, rotation of neck, avoiding restrictive neck tapping, minimizing stimuli that could induce cough, valsalva response such as endotracheal suction. About temperature control, the bundle of prophylactic measures to improve treat intracranial hypertension include temperature control. As it is known, elevated temperature affect ICP by increasing cerebral metabolic demand and cerebral blood flow. It has been shown that patients with ICH who develop body temperature of more than 37.5 within first 72 hours had significantly worse outcome determined as Glasgow Outcome Scale. In addition, later study of 110 TBI patient
It is demonstrated that fever within first week was associated with increased ICP and significant neurological impairment, prolonged ICU stay. Due to harmful effect of increased temperature on cerebral parenchyma, it is recommended that it should not exceed 37 degrees. To this end, early aggressive measure to control temperature in patient should be implemented. These include intravenous and enteral antipyretic medication, control of room temperature, and cooling blanket and pads. A French study involving patients with septic shock showed that fever control using external cooling was safe and decreased vasopressor requirement and early mortality. Regarding early hypothermia induction as a primary neuroprotective strategy in severe TBI patients, two recent randomized multicenter clinical trial did not confirm its use given prophylactic hypothermia was associated with poor outcome. The TBI guideline do not recommended early, that is within 2.5 hours, short-term prophylactic hypothermia to improve outcome in patient with diffuse brain injury. About glycemic control, hyperglycemia is associated with increased mortality. It remains unclear what are the optimal blood glucose level, but it is showed that normal blood glucose level between 80 to 110 are associated with decreased mortality, morbidity, and decreased hospitalization. So, the guidelines for treatment of hyperglycemia in critical ill patient suggest blood glucose level of less than 100 should be avoided. In addition, they also suggest that blood glucose of more than 150 trigger the initiation of insulin therapy for most patients admitted to the ICU. So, broad range of maintaining blood glucose level is between 140 to 140 to 180. About seizure control, seizure can exacerbate intracranial hypertension by increasing cerebral metabolic rate of oxygen and cerebral blood flow. So patient with acute brain injury, they are at increased risk of seizure because of reduction of threshold for epileptic discharges by underlying structural and functional injury. The use of prophylactic anti-epileptic treatment for prevention of SBI was the topic of investigation. In randomized double-blind study, Temkin et al. Examined the role of phenytoin in the prevention of early and late post-traumatic seizure. The recent Brain Trauma Foundation guidelines are in accordance with this result and do not recommend the prophylactic use of phenytoin and valproate for prevention of the late seizure. Phenytoin is recommended to decrease incidence of early post-traumatic seizure when overall benefit is failed to outweigh the complication associated with such a treatment. Prophylactic anti-epileptic therapy in other acute neurological condition is not recommended. About acute intervention, hyperventilation. Hyperventilation is effective, rapid method of treating intracranial hypertension reduction of PaCO2, induces vasoconstriction of cerebral arterioles, decreased cerebral blood flow, and ICP reduction. The effect is almost immediate but generally lasts less than 24 hours. As CSF pH rapidly equilibrate to new PaCO2 level. Hence, prolonged and aggressive hyperventilation may lead to critical decrease in local cerebral perfusion, ischemia, potentially resulting in worsening neurological injury in first 24 to 48 hours. Therefore, hyperventilation have a role in temporizing measure for reduction in ICP. Meanwhile, jugular venous saturation and PbO2 measurement can be used to monitor oxygen delivery. It is worth noting that hyperventilation should not be abruptly discontinued, but should be tapered slowly over 4 to 6 hours to avoid vasodilation of cerebral arterioles and rebound increase in ICP. Hyperosmolar therapy is the cornerstone of medical management of acute intracranial hypertension. The most commonly used medication are mannitol and hypertonic saline. Osmotic agent reduces brain tissue volume by drawing free water out of brain tissue into systemic circulation, where it is then excreted by the kidney. The beneficial effect of hyperosmolar therapy requires intact blood-brain barrier. However, as in traumatic contusion, blood-brain barrier disruption allows equilibration of molecule between blood and interstitial fluid of the brain. Thus, osmotic agent exerts their effect largely by removing water from remaining normal brain tissue. Mannitol acts by increasing serum osmolarity, resulting in osmotic gradient from interstitial to intravascular space, resulting in reduction of cerebral edema, consequently IC. Mannitol also act by other mechanisms such as induction of reflex cerebral arterial vasoconstriction, improvement in blood rheology, reduction in CSF formation, free radical scavenging. Its effect is dose dependent since positive correlation has been demonstrated between dose and magnitude of ICP reduction. The recommended ICP lowering dose of mannitol is 0.25 to 1 gram per kg every 6 hourly, although less 0.5 gram per kg are usually considered less effective. Serum osmolarity should be maintained between 310 to 3 and 320 mmol per liter, while some research advocates that even higher level can be cautiously tolerated. Mannitol is excreted entirely in the urine, and there is a risk of acute tubular necrosis if serum osmolarity exceeds this recommendation level. Other adverse effects of mannitol include hypotension, electrolyte disturbance like hyperkalemia, hypokalemia, hypomagnesemia, hypophosphatemia, and rebound cerebral edema after prolonged use. Mannitol is contraindicated in patients with renal failure due to risk of osmotic nephrosis and possible pulmonary edema and heart failure. Hypertonic saline is alternative to mannitol. Therefore, hypertonic saline is less able to cross blood-brain barrier and may have stronger osmotic dilution action. Thus, it reduces ICP by decreasing cerebral edema, while at same time increase cerebral perfusion pressure by improving MAP. Other mechanism of action include induction of reflex cerebral arterial vasoconstriction, improved deformability of erythrocyte with enhanced microcirculation, and anti-inflammatory effect due to reduced adhesion of monomolecular cell in the cerebral microvasculature. In literature, concentration of hypertonic saline used to treat intracranial hypertension were ranges from 3% to 23.4. Bolus dose was administered in response to measured ICP and may be repeated as needed until either ICP is an acceptable range or serum sodium concentration have risen above normal, that is 145 to 155. Possible adverse effect of hypertonic saline include rebound cerebral edema, electrolyte disturbances, congestive heart failure, renal failure, hyperchloremic metabolic acidosis, phlebitis, transient hypotension, hemolysis, osmotic demyelination, subarachnoid bleeding, seizure, and muscle twitching. About sedation and analgesia. Sedation and analgesia are integral part of the medical treatment of the intracranial hypertension. Patient ventilator dysynchrony and agitation increases intrathoracic pressure, causing decreased thoracic venous return, which increases cerebral blood volume and thus ICP. In addition, agitation contributes to the increased ICP by elevating systemic blood pressure, especially in patients on extreme autoregulatory curve. Under these conditions, CMRO2 and brain tissue oxygen demand are increased, leading to vasodilation, consequent increase in cerebral blood flow, cerebral blood volume, and ice. Propofol is one of the preferred drugs for sedation in patients with intracranial hypertension, although there is no evidence that it improves mortality or 6-month outcome. It has relatively quick onset and offset of action, allowing for more rapid assessment of neurological status. Conversely, reduced clearance of benzodiazepine after prolonged infusion can significantly delay arousal, especially in the adults. Additional benefit of propofol include increased seizure threshold and better quality of sedation when compared to midazolam. However, one should be aware of its hemodynamic effect as it can cause reduction in MAP, which may require fluid resuscitation, or even vasopressor to maintain CPP. Finally, propofol can induce lethal propofol infusion syndrome, characterized by lactic acidosis, rhabdomyolysis, renal failure, arrhythmia, and cardiac failure. Given that pain is often a contributor to the raised ICP, especially in TBI patients, co-administration of fentanyl can work synergistically with propofol to reach sedation goal. However, paradoxical rises in ICP may occur following bolus injection of fentanyl due to transient MAP lowering and reflex cerebral vasodilation to maintain CBF. Remifentanil has more favorable pharmacokinetic property and in particular lower volume of distribution and very short half. ICP may decrease without substantial changes of CPP, but the exact effect of cerebral hemodynamics remain to be elucidated. NM blocking agent could be used in the control of refractory intracranial hypertension in specific conditions such as very severe agitation, shivering, and difficult ventilation. However, few studies exist to support this as routine practice. About barbiturate therapy is supported by literature on failure of other conservative treatment of intracranial hypertension and include the use of pentobarbital and thiobarbital. Pentobarbital suppresses the brain metabolism, reduces cerebral blood flow, improves oxygenation and cerebral of the cerebral tissue. Marshall et al. In the study of 55 patients with severe TBI and refractory intracranial hypertension treated barbiturate showed that 40% of them survived at discharge and 68% of survivors had good functional outcome. Later, Cochrane analysis did not reach the same conclusion, noting that barbiturate may reduce the ICP, but there is no difference in the death and disability measured using GOS in patients with acute traumatic brain injury. However, according to the Brain Trauma Foundation guideline, high dose of barbiturate administration is recommended to control ICP refractory to the maximum standard medical and surgical treatment. They also emphasize that hemodynamic stability is essential before and during therapy. Due to their long duration of action, barbiturate limit the ability to perform frequent neurological assessment. The limitation warrants the need of continuous EEG monitoring. Other important adverse effects of barbiturate include hypotension, myocardial respiratory depression, infection, liver and renal dysfunction, thrombocytopenia, metabolic acidosis, and gastric stasis. Now about therapeutic hypothermia. Hypothermia decreases cerebral metabolism, may reduce cerebral blood flow and IC. However, to date, literature data are inadequate to support its neuroprotective effect. Indeed, favorable neurological outcome and reduced mortality using therapeutic hypothermia have only been demonstrated after ventricular fibrillation and ventricular tachycardia, cardiac arrest. Recently, a study of Nielsen et al., which involved patients with out-of-hospital cardiac arrest, showed different results. In particular, there was no difference in neurological outcome or survival at targeted temperature of 33 degrees Celsius versus 36 degrees Celsius. So, regarding the treatment of traumatic brain injury, systemic review and meta-analysis showed that therapeutic hypothermia may be benefit in reducing rate of death and vegetative state and long-term disability. However, there remains need for more and higher quality RCT in this patient population. Lastly, Andrew et al. Compared therapeutic hypothermia plus standard care with standard care alone in 387 patients with ICP of more than 20 mmHg after TBA. They concluded that hypothermia does not improve long-term outcome, determined as extended GOS 1 to 4 at 6 months, although it appeared to reduce ICP and PBT. Serious adverse effects are associated with hypothermia, especially if used for a long period of time. So hypokalemia, atrial ventricular arrhythmia, hypotension, coagulopathy may occur with risk of infection, particularly ventilator-associated and nosocomial pneumonia. About corticosteroid, the role of corticosteroid in treatment of elevated ICP is limited. MRC crash trial, which included approximately 10,000 TBI patients, evaluated methylprednisolone versus placebo. A steroid-treated patient had significant higher mortality compared to placebo. So, according to the Birenturner Foundation guidelines, steroids are not recommended. So steroids are not recommended for treatment of cerebral edema and increased ICP, complicating ischemic stroke because of lack of evidence of efficacy and potential to increase the risk of infectious complication. Except infection, corticosteroids also carry additional risks such as hyperglycemia, impaired wound healing, muscle catabolism, and psychosis. Finally, steroid is only indicated for reducing ICP in abscesses or neoplasm associated with vasogenic edema. Resection of mass lesion. Based on specific indication and condition, resection of mass lesion may immediately lower IC. The large international multicenter randomized stage 2 trial included 601 patients with spontaneous supratentorial lobar ICH without intraventricular hemorrhage or hydrocephalus, treating them with either early surgery or conservatively. It showed that early surgery does not increase the rate of death or disability at 6 months and might have small but clinically relevant survival advantage for patients with spontaneous superficial ICH without intraventricular hemorrhage. So recent guideline for spontaneous ICH recommended surgical removal of hemorrhage as soon as possible for patients with cerebral hemorrhage who are deteriorating neurologically or who have brainstem compression and hydrocephalus from ventricular obstruction. In addition, they emphasized that supratentorial hematoma evacuation in deteriorating patient might be considered as life-saving measure. Other acceptable indication for removal of mass lesion include evacuation of subdural and epidural hematoma, brain abscess, resection of brain tumors. Stitch compares early surgery with initial conservative treatment in 170 patients with traumatic ICH. They concluded that early surgery was associated with significant fewer death in first 6 months compared to conservative treatment. However, further well-designed trials are required to assess whether this encouraging signal can be confirmed in the TBI patient. Now about decompressive craniotomy. Decompressive craniotomy, which consists of creating large bone window, provides larger reserve to swollen brain, negating the Monro-Kellerin doctrine of fixed intracranial volume. In this way, decompressive craniotomy alone lowers the ICP by 15% with dural opening by 70%. The main indication of decompressive craniotomy is massive hemispheric ischemic stroke. Meta-analysis of three RCT, Decimal Trial, Hamlet Trial, and Destiny Trial showed that early, that means less than 48 hours decompressive craniotomy in massive ischemic stroke significantly improved survival and resulted in better neurological outcome measured using MRSA at 1 year compared to conservative therapy. In literature, two more recent reviews and meta-analysis reached the same conclusion. This guideline for ischemic stroke note that decompressive surgery may be only effective option for very severe cases, but decision making should include patient-centered preference. In patients with spontaneous ICH, decompressive craniotomy with or without hematoma evacuation might reduce mortality. For patients with supratentorial ICH who are in coma, have large hematoma with significant midline shift, or have elevated ICP refractory to medical management. So regarding TBI, recent BTF guideline do not recommended bifrontal decompressive craniotomy to improve outcome as measured by GOSE at 6 month post-injury. Although this procedure has been demonstrated to reduce ICP and to minimal days in ICU. These guidelines are based on DECRA trial, which involved 155 patients with diffuse TBI and refractory intracranial hypertension. In this trial, early bifrontotemporal parietal decompressive craniotomy decreases ICP and length of stay in ICU, but was associated with more unfavorable outcome indicated by GOSE at 6 months after injury. However, study faced intense criticism and some authorities claimed that it should have no influence on clinical practice. Later rescue trials showed decompressive craniotomy has favorable result on outcome. Patient with traumatic brain injury and refractory intracranial hypertension underwent decompressive craniotomy and received ongoing medical care were randomized. At 6 months, decompressive craniotomy resulted in lower mortality but higher rate of vegetative state and severe disability than medical care. However, most studies are required to determine which patient will benefit with mortality reduction but minimize risk for vegetative state and poor functional outcome. About CSF drainage. CSF drainage, even 5 to 10 ml, may lead to increased ICP reduction in patients with low intracranial compliance. This can be accomplished by external ventricular drainage, lumbar drain, and serial lumbar puncture. CSF removal via EVD is preferred over the use of lumbar drain due to risk of transtentorial herniation. EVD placement with continuous drainage of CSF for acute hydrocephalus treatment is also supported by guidelines of for TBI, spontaneous ICH, and ischemic stroke. Except obstructive hydrocephalus, other indications of CSF drainage include diffuse cerebral edema, mass effect due to space occupying lesion. Finally, it should be noted that major risk of EVD placement include infection and hemorrhage. So this is the algorithm for management of intracranial hypertension or herniation. Tier 0 include assess the ABC, minimize noxious stimuli, give analgesia sedation, target normothermia, elevate the head end of the bed by 30 degree, keep the neck in the midline position, iso and hyperosmolar fluid, avoid and correct hyponatremia, steroid in select condition, and obtain non-contraceptive. Tier 1 includes use of hyperosmolar therapy, target hyperventilation to PaCO2 of 30 to 35, CSF drainage, and consider surgical decompression. Tier 2 includes hyperosmolar therapy for higher sodium goal, optimized sedation analgesia, rescue decompression surgery should be considered as a life-saving. Tier 3 includes sedation titrated to ICP goal, birth suppression on a continuous EEG, hyperventilation to achieve mild to moderate hypocapnia, that is between 25 to 34, and moderate hypothermia. Thank you, guys.